our new star, Dr. Khalid Bamakrama, consultant gastroenterologist, and he is expert in endoscopic procedures, especially in pancreatic diseases. And he will talk to us on pancreatic cystic lesion. Dr. Khalid, welcome. Are you with us?
السلام عليكم. Can you hear me?
Khalid.
كيف الحال?
Our rising star.
I'd like first of all to thank the organizer, Dr. Salem and Dr. Maki, for this opportunity. Proud to participate. So my task today is pancreatic cystic lesion, and these are my objectives. So why do we care about pancreatic cystic lesion? And what are the type effects? They are very important: classification, diagnosis, management, and the guidelines. So I'm going to start with this case. This is a 48 years old who was referred to our hospital with upper abdominal pain, recurrent from a private hospital. And the CT scan, you can see there was a cyst around 4 and 4 centimeters. And this is the CT scan, and this is the MRI of this lesion. So how to diagnose these lesions and how to treat this lesion. So why are we talking about pancreatic cystic lesion? Pancreatic cysts are common. The prevalence is 7 to 40% individual above 50, and if you see 25% between 70 and 79 years of old. Now, the cumulative prevalence is 13.5%, and the pancreatic cyst can progress to cancer. Pancreatic cancer is the 4th leading cause of cancer death in the United States. Death to incidence is almost 100%. So, pancreatic adenocarcinoma, if you will see the 5-year survival rates, is only 8.5%. And that's really a very, very low. If you will take it to the other cancer, the prostate cancer, for example, the 5-year survival is 98%. Breast cancer is 90%, and the colon cancer, the 5-year survival is 65%. So we are doing very bad in terms of the pancreatic adenocarcinoma. This is a Japanese study of 200 cases of multi-center studies. The Japanese showed us that the survival rates can be improved from 80 to 94% in the early stage of pancreatic cancer, those with high-grade dysplasia or stage 1 cancer. Not only the 5-year survival, which is reaching up to 80 to 94%, but even the 10-year survival, which is almost reaching to 80%. Okay, so early diagnosis is very critical in the improvement of the survival. Okay, so Khalid, what is the relation between the pancreatic cystic lesions to the adenocarcinoma, pancreatic adenocarcinoma? If we will see the precursors of the adenocarcinoma, there are 3 main precursors. The first precursor is the pancreatic intraepithelial, which will give you cancer. The other is the mucinous cystic neoplasm, which will give you again adenocarcinoma. And the other is the intrapapillary mucinous neoplasm, which will give you again adenocarcinoma. So two out of these 3 precursors are because of the pancreatic cystic lesion. So this is the importance of the pancreatic cystic lesions. Types of the pancreatic cyst: benign serous cyst adenoma, pseudocyst, lymphoid epithelial, lymphangioma, and retention cyst, and pre-malignant or malignant cysts, which are very important: mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, solid pseudopapillary neoplasm tumor, or neuroendocrine tumor with cysts, acinar cell carcinoma, or metastasis. So what I'm going to focus on is the MCN, or the mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, serous and pseudocysts, which are quite very common to be seen. The classification of pancreatic cyst, again, from the lining epithelium. Pseudocyst, there is no any lining. MCN and IPMN, you can see that the epithelium is producing mucins. Serous in serous cystic neoplasm, squamous in lymphoepithelial, acinar cell carcinoma, and solid tumor degenerations like neuroendocrine tumor. The common Pancreatic cyst, again, divided in two main groups: no malignant potential like pseudocysts, serous cyst adenoma, retention cysts, and lymphoid epithelial cyst. And the malignant potential, which is really our cautious when we are doing intervention, the intraductal papillary mucinous neoplasm, the mucinous cystic neoplasm, the cystic neuroendocrine tumor, and solid pseudopapillary neoplasm. So what is the accuracy of CT or MRI in the diagnosing of this cyst? 40 to 50% for determination of the cyst type, and up to 80% to identify benign from malignant cell. The other important question, CT versus MRI, what is the best? The MRI is considered the test of choice because it is non-invasive, lack of radiations, assessment of ductal communication. Not only this, but also it will give you a determination of the morphological, like the septa, nodules, and ductal communication better than the CT scan. And you can give you up to 90% sensitivity and specificity of detecting the ductal communication, which is lacking in the CT scan. So the cyst is the sequence of acute or chronic pancreatitis. They can be single or multiple, located anywhere, and communicate with the main pancreatic duct. The cystic fluid, low CEA cytology will give us macrophage, and obviously they are high amylase and they are benign, and very, very, very late to have pseudocysts in the absence of history of pancreatitis. The other important pancreatic cystic lesion is serous cyst adenoma, 75% female, usually present in their 50s. 9% will present with symptoms, single, located at anywhere in the pancreas. They are tiny cyst, microcystic, or macrocystic also can be seen, and there is a scar of calcifications. The cystic fluid, if you will aspirate, usually it will be bloody, low CEA, no mucin, VHL mutation is positive, and the risk of the malignancy is very, 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 very low. This is one of our patients who was referred again with cystic lesion, and you can see that from this picture, the microcystic and macrocystic lesions and the typical appearance of the serous cyst adenoma. So this is a very classical picture of serous cyst adenoma, and those patients they don't need any surveillance. So the key point of serous cyst adenoma, they are benign, no need for surgery or surveillance. If asymptomatic, leave alone. If symptomatic, they need resection, like if they are causing obstructive jaundice. Now, the other important pancreatic cystic lesion is the mucinous cystic neoplasm, predominant in female, 95%, usually mid-40s, single cyst, 90% are located in the body and tail, no connection to the pancreatic duct, and the cyst fluid analysis, you will find high CEA and mucin also, the KRAS mutations, and low amylase. The risk of cancer is up to 12%. So this is one of the really important pancreatic cystic lesion to be taken in your considerations. So going back to our patient with the pancreatic cystic lesion at the tail, this is the US of the patient. You can see that there was a thickening of the wall, and there was also a splenic vein thrombosis. I saw it here, you can see, and there is no nodules that I could appreciate. And you can see that there was some debris at the base of the cyst, and it could be hemorrhage, or it could be mucin, or it could be debris. So that's why. So this is again the splenic vein thrombosis. You can see, you can follow the spleen all over the pancreas, and then you can see to the confluence, and this is the thrombosis you can see at the confluence. So after that, we aspirated the fluid, and very important to aspirate the whole cyst And you can see I tried to go to the side because of the intervening vessels, but we aspirate the whole cyst completely, and that's very important in order to minimize the infections. Not only this, but also after that, you can do a proper FNA from the collapsed cyst, which will give you more accurate, more results. So this is the fluid cyst of the cyst. You can see the amylase was 64, CA is 584. The cytology was negative for malignancy. The molecular markers are negative for mutations. But the patient, she is symptomatic, and the size is 4 and 4, and the CA was high. The patient underwent distal resection of the distal pancreatectomy, and it was confirmed that it is mucinous cystic neoplasm. The other important pancreatic cystic lesion is the IBMN. We have three major types: the diffuse main pancreatic duct, and we have the branch duct IBMN, and we have the mixed type, and we have sometimes you can have segmental main pancreatic duct. You can see the MRI, the beauty of the MRI that to diagnose the lesions. Here you can see the pancreatic duct, which is not dilated, and here is the branch duct IBMN. Here you can see the diffuse dilatations, and here you can see the segmented dilatation, and here is the mixed type. So the MRI is really very important to give you the way how to take those cysts and to diagnose them. Branch duct IBMN equal male to female distributions, 40 multiple cysts located anywhere, communication with main pancreatic duct, cyst fluid, high CA, mucin KRAS, GNAS mutation is plus minus. So the branch duct IBMN, most will not develop pancreatic cancer, and the majority need surveillance. The annual risk of pancreatic ductal adenocarcinoma with side branch IBMN, you can see that 4,000 patients, the overall risk is 2.8, 0.7 per year. And if you will see the 5 years is 3.1 and 7.7 in 10 years. So it is relatively lower than the main duct IBMN. So it's very important to differentiate the pancreatic cyst from the imaging, the EUS, the morphology, the communication with pancreatic duct, cytology, and fluid analysis, CEA, mucin, amylase, and molecular analysis, and that's will EUS FNA will give you the answer. So the technique of EUS FNA, usually if you want to take fluid from a cyst, make sure that it is more than 1 centimeter, because less than 1 centimeter in the majority you will not find any. It's very difficult to aspirate it. 22 gauge needle, but sometimes I use 19 gauge needle because it will give you more fluid, especially if it is thick. One pass and drain the entire cyst completely. This is a very important FNA of the collapsed cyst wall for cytology. Target nodules and solid component for the FNA. Assess for the string sign, cyst, CAA, amylase, and very, very important to give prophylactic antibiotic. And this, the procedure is very safe, 2.2% complications. If you see the CEA for the accuracy of diagnosing mucinous cyst, the cutoff is 192, and you can see the sensitivity is 63% and specificity is 93%. String sign is to put a drop of the fluid between your fingers and measure the maximum length before breaking. The string sign is positive if it is more than 1 centimeter and more than 1 second, and the specificity is 95, and positive predictive value is 94%, highly specific for mucinous cyst. But keep it in your mind that if it is negative, does not rule out that this cyst is mucinous. Very important to differentiate the nodule from the mucinous ball. Usually, you will see that the mural nodule, it's irregular. There is no rim, okay, and it is iso or hyper-echoic compared to the rest of the pancreas. While the mucin ball, you can see that there was a hyper-echoic ring, smooth edge and round, and it is hypoechoic compared to the rest of the tissue. The other thing is that when you will FNA mucin pole, you can see that you can remove it completely from, and it is mobile. This is one of the really important sign, while the nodules, it will not be mobilized and it will be the same. Histology, we can use the needle biopsy forceps, and the diagnosis key is slightly more better with 36 to 84%, but there is some superiority in the cytology or CEA, but the adverse event is higher than the traditional conventional FNA. Diagnosis of with EUS, it will give you the morphology up to 51% accuracy, cyst cytology 63, cyst wall cytology 29 increased yield, and CA 192, 75 and 84 specificity, string sign 94 and specificity and 94 positive predictive value, and of course the molecular markers can help us to differentiate between IPMN and MCN. EUS, there is minimal risk factor, and these are, you can see the pancreatitis is less than 1%, fever, bleeding, and infection also, again, they are less than 1%. Continence enhanced EUS are, again, something that can help us to see if there's any mass or if there's any nodules, and we can use the SonoView substance to elaborate this enhancement. The guidelines are many. We have a lot of guidelines. We have the AGA in the management of asymptomatic kidneyplastic pancreatic cyst. We have the international consensus by Fukuoka in Fukuoka guidelines in the management of IPMN that came in 2017. We have the European Evidence of Guidelines 2018, and we have the ACG guideline that came in 2018. So one thing is that out of these guidelines, I think the most important is the Fukuoka guidelines, the European and the ACG, but the AGA made a lot of controversies in the field of pancreatology. So there is a few no-brainer concepts. If you have a patient who is symptomatic with cystic lesions causing obstructive jaundice, then those patients are straightforward case for surgery. If there's any associated mass, again, surgery. Consider surveillance only if the patient is willing to go under for surgery and patient is candidate for surgery. So if you have a patient who has a lot of comorbidity and he's not candidate for surgery, no need to do any surveillance for those cases. This is the ACG guidelines 2018, which will give you kind of highlight or algorithm for how to take this cyst in general. So if you have a cyst and imaging, obstructive jaundice or mass, you need to straightforward take this patient in multidisciplinary group. If there is no mass, then you need to assess if there's any dilatations with EUS, cyst more than 3 centimeter, change in the main pancreatic caliber. If yes, you can go for EUS, FNA. If there is any involvement of the main duct, if there's any high-grade dysplasia or pancreatic cancer or nodule, then those patients, they need to go for surgery. If nothing of these, then you need to see the size of the cyst. If they are less than 1 centimeter, MRI after 2 years. If it is more than between 2 and 3 centimeters, then you need to go for surveillance, especially if they are IPMN or MCN. Then you need to do every 6 months MRI or EUS. So the international consensus guidelines revised Fukuoka that came in 2017. The high risk stigmata of malignancy on the side, jaundice, especially if it's caused by a mass, enhancing neural nodule more than 5 millimeter, main pancreatic duct more than 10 centimeter, 10 mm. These are direct indication for surgery. If you don't have this, but you have a cyst which is around 3 centimeters, enhancing nodule less than 5 mm, thick wall or enhancement wall, main duct between 5 and 9, or there is an increase in CN19 and lymphadenopathy, and then you need to take your patient for endoscopic ultrasound. If you have nodules more than 5 millimeter, cytology suspicious of malignancy, those cases are for surgery. If no, then you need to keep your patient for surveillance. The European Consensus Guidelines 2018, absolute indication for surgery, again, cytology for high-grade dysplasia or malignancy, solid mass, jaundice because of tumor, enhancing nodules more than 5 mm, and pancreatic duct more than 10. Now, if you have a relative indication, growth more than 5 mm, increase serum CA19, main duct between 5 and 9, and cyst more than 4 centimeter, new onset diabetes, acute pancreatitis, enhancing neural nodules, all these are relative, and then you need to take those relative cases based on the comorbidity. If it is only one, then surveillance. If there are two and the patient is candidate, you might consider surgery. If you have the absolute, then surgery. If the patient is unfit for surgery, no surveillance. As I mentioned, the AGA should not be used because of the loss of the accuracy, and you can see that there is a loss of malignant cyst up to 25 by the AGA guidelines. So to conclude, ladies and gentlemen, pancreatic cysts are common. If you have imaging that or EUS that confirm the pseudocyst or serous cyst adenoma, these lesions are non-malignant and they don't need surveillance. So the management of those only if they are causing symptoms for serous cyst adenoma resection and for the pseudocyst drainage, as Abid elaborated in his presentations. Now, the extreme is pancreatic adenocarcinoma or solid pseudopapillary neoplasm. Those are straightforward cases for surgery. If you have IPMN or MCN, those are the lesions that have potential malignant potential. So if they have direct sign of worrisome, they can go for surgery. If no, surveillance. MCN, if you resected, no need for surveillance. IBM, if resected, need surveillance. Thank you very much.
Thank you, Khalid. I think the time come now for the artificial intelligence to solve